Hello friends, today we are going to discuss the question which was asked in DRNB Critical Care exam in October 2023. That is a time-dependent antimicrobial. Now, along with time-dependent antimicrobial, we will also discuss the concentration-dependent Time-dependent killing refers to the time it takes for the pathogen to be killed by exposure to the antimicrobial agent. The goal of time-dependent killing is to optimize the duration of the exposure. With time-dependent killing, the post-antibiotic effects are minimal. The study of movement of the drug from its administration site to the place of pharmacological activity and its elimination from the body is called as pharmacokinetic. So factors affecting the movement and the fate of the drug in body are release from the dosage form, absorption from the site of administration into bloodstream, distribution into various parts of the body including site of action, and rate of elimination from the body by metabolism or excretion of unchanged drug. These processes are often referred to by using acronym like ADME, that is absorption, distribution, metabolism, and excretion. ADME parameters of the drug are described by the various terms like maximum concentration of the drug in serum, time to maximum concentration of the drug in serum after dose, and the half-life of the drug in the serum. That is area under curve over 24 hours from time of administration to infinity, representing the concentration of the drug in the serum over time, and clearance of the drug from serum, which may include the renal or non-renal clearance. Pharmacodynamic correlates the concentration of the drug with its pharmacological and or clinical effect. For antibiotic, this correlation refers to the ability of the drug to kill or inhibit the growth of microorganisms. So antibiotic elicit their activity against the bacteria by binding to the specific protein or structure in the organism. So for antibiotic to eradicate organism, three major factors must occur. First, antibiotic must bind to the target site in the bacteria. To reach the binding site is no easy matter. It must penetrate the outer membrane of the organism, that is penetration resistance. Avoid being pumped out of the membrane, that is efflux pump resistance, and remain intact as a molecule. Once reaching its target, the antibiotic can still be frustrated if the binding site has changed its molecular configuration and now no longer allow the drugs to attach. So until antibiotic overcome all these obstacles, there is no detrimental effect on the organ. The range of different binding site has been identified, including ribosome, penicillin binding protein, DNA topoisomerase gyrase, and the cell membrane itself. The crucial binding site varies with the antibiotic class. This binding site can be defined as a point of biochemical reaction within the bacterium, which must be properly executed to continue cell's life cycle. By binding to them, the antibiotic interfere with the crucial chemical reaction, resulting into the death of the bacteria. The two major determinants of the bacteria killing include concentration and the time that antibiotic remain on its target binding site. The integration of how high and the how long an antibiotic level remain above zero concentration over dosing interval is referred to as area under plasma concentration curve. In essence, the area under concentration curve measures the concentration of the drug over a given time period and reflects the amount of exposure of organism to antibiotic overdosing interval. So for certain classes of antibiotic, the major killing effect against an organism produced by either the time or concentration of the drug at the binding site. Of these two factors of the bacterial killing, one may be so minimal in the killing process that it can be ignored in the prediction of clinical response. For instance, the certain antibiotic like beta-lactam, cephalosporin, carbapenem, monobactam and beta-lactamase inhibitor, clindamycin and macrolide and oxalodenedons and vancomycin, they use mainly time and binding site to eradicate organisms. Apparently, once concentration exceeds the critical value, which seems to be about 2 to 4 times above minimum inhibitory concentration for organism, bacterial killing proceeds to zero order rate, and the increasing drug concentration does not increase the microbial death. As a result, these antibiotics are referred as concentration independent and time dependent antibiotics. So for these drugs, the duration that antibiotic concentration remain above their MBC or MIC in any one dosing interval becomes the best predictor of the clinical outcome. For beta-lactam antibiotic, the time above MIC and minimal binding capacity for the drug in serum is generally proportional to that in the fluid within the organism because the antibiotic distributes to the extracellular water which is dynamic equilibrium with the serum. So example of the time dependent antibiotic are beta-lactam, uh, like penicillin, cephalosporin, carbapenem, beta-lactamase inhibitor, monobactam, clindamycin, erythromycin, clarithromycin, linezolid, and vancomycin. This is the pictorial representation of time-dependent antibody, where the time should be, the exposure time should be above minimum inhibitory concentration for bacterial kill. Now the next is concentration-dependent antibody. Certain classes of antibiotic, however, like aminoglycoside and quinolone, use mainly concentration at the binding site to eradicate organisms. Unlike concentration-independent killing antibiotic, the aminoglycoside and fluoroquinolone eliminate bacteria most rapidly when their concentrations are appreciably above their minimum inhibitory concentration for organisms. Hence, their type of killing is referred to as concentration-dependent and dose-dependent. For this drug, the rate of bacterial eradication rises with increasing concentration up to specific amount. After the specific concentration is achieved, increasing concentration further does not increase the magnitude of bacterial killing. If concentration is high enough, most bacteria die within the short time. So if in this condition, the effect of duration of the drug exposure is minimal. For concentration dependent agent, the pharmacodynamic parameter of area under curve and minimum inhibitory concentration and uh, uh, T by MIC can be simplified to peak or Cmax or MIC. For agent with the concentration dependent killing like aminoglycoside or fluoroquinolone, best response occur when concentration are greater than or equal to 10 times above MIC for their target and organism at the site of infection. For agents with concentration dependent killing, it has been shown that clinical response can be predicted in the peak by MIC ratio by measuring antibiotic area under curve over dosing interval and dividing that value by its MIC against the target organism. In essence, the AUC upon MIC ratio becomes the default PD concept for peak by MIC ratio for antibiotic with concentration dependent killing. So this is the pictorial representation of concentration dependent killing where the concentration should be above the minimum inhibitory concentration. So clinical application of concentration independent and time dependent killing. For antibiotic with time dependent and concentration independent killing like beta-lactam, the often mentioned advice in package insert is that drug should be given in larger and more frequent doses for infections considered to be severe as compared to those that are deemed mild or moderate. It should be remembered that high serum level of beta-lactam antibiotic do not drive more drug intracellularly or into tissue because these agents exhibit insignificant intracellular penetration. The poor intracellular penetration of beta-lactam antibiotic is explanation why these agents do not eradicate intracellular pathogen like chlamydia, mycoplasma, and legionella. So there are 5 ways to prolong the duration of beta-lactam concentration above its MIC for bacteria in any dosing interval. That is, use another drug that interfere with this elimination, dose frequently, increase the dose of the antibiotic, replace with another therapeutic equivalent antibiotic with longer serum half-life and administered by constant infusion. Although probenecid blocks the renal tubular secretion of most beta-lactam antibiotic, it may do same for the other drug, resulting in unexpected adverse reaction. Moreover, the patient develops hypersensitivity reaction. It is difficult, if not impossible, to determine whether the reaction was caused by probenecid or the antibiotic. Dosing frequently or increasing the dose is usually unacceptable in today's medical era of physical restraint because of excessive cost from the high drug acquisition cost and the ancillary service time. Moreover, the doubling dose of the beta-lactam antibiotic is generally insufficient, yielding the increasing T greater than MIC of only half-life. Using antibiotic with longer half-life is sensible as long as the one with longer half-life is therapeutically equivalent and is not appreciably more expensive. Example of this interchange include replacing cephalothin with cephalozolin and cefoxitin with cefotitan, cefotaxime with ceftriaxone. There has been renewed interest in administering beta-lactam antibiotic by 24-hour constant infusion because this represents an easy way using least amount of the drug supply and the labor cost to maintain drug concentration above antibiotics MIC for entire day or 100% dosing interval. For Pseudomonas beta-lactam, constant infusion dosing method are alternative dosing approach because most of the agents have relatively short half. For instance, recommended dose in the package insert of piperacillin tazobactam to treat nosocomial pneumonia is 4.5 gram every 4 to 6 hours. Moreover, in study comparing intermittent with constant infusion, ceftazidime with nosocomial pneumonia, similarities were noted in clinical outcome, but major reduction in the cost associated with constant infusion. Further clinical outcome studies are needed to confirm whether this constant infusion dosing method will become the preferred dosing approach for those beta-lactam that have relatively short half-life and require high daily dose. So example with mechanism of action of time-dependent antibiotic is beta-lactam. Mechanism is inhibiting cell wall by binding to penicillin binding protein. Then macrolide inhibit protein synthesis by binding to 50S ribosome. Then lincosamide, which inhibit protein synthesis by binding to 50S ribosomal subunit. Example is clindamycin and lincomycin. Then the other example is vancomycin, which inhibits cell wall by binding to DLR terminus of peptidoglycan precursor. Now, evidence is continuous infusion of beta-lactam was studied in Blink trial, which showed the benefit in using continuous infusion. Then another trial was published, with this Mercy trial, which compared the intermittent infusion of meropenem with frequent dose interval. And according to this, the continuous administration of the drug did not improve the composite outcome of the order. Now, clinical application of concentration dependent antibiotic. Being concentration dependent drug, aminoglycoside eradicate organism best when they achieve concentration that are greater than or equal to 10 times above their MS. In animal model of infection, many more animals survive potentially lethal challenge of bacteria if aminoglycoside is given as a single daily dose than when given in the divided doses on every 8-hour basis. To obtain this favorable ratio, the aminoglycoside should be given at a dose of 7 mg per kg once daily, but may be given even less frequently in patients with renal dysfunction. This 7 mg per kg dose usually achieves peak serum concentration of 20 mg per ml, thereby achieving target of 10 times above the MIC for this aminoglycoside. In meta-analysis comparing once daily aminoglycoside with intermittent dosing in immunocompetent adult, once daily dosing was equivalent with regard to bacteriological cure. but showed trend towards reduced mortality and reduced toxicity. Compared with intermittent dosing, once daily dosing of aminoglycoside has shown less rather than more damage to the tissue, like organ of porta renal tubular cell and on pathological examination. The toxicity or nephrotoxicity of aminoglycoside correlate with tissue accumulation and not peak concentration in serum. Further advantages of once daily aminoglycoside dosing include reduction in supply, labor cost, and emergence of bacterial resistance. This new once daily dosing method of aminoglycoside based on PD concept mentioned previously has emerged as preferred dosing method except for patients with enterococcal enterocarditis, pregnancy, ascites, renal dialysis, and burns. Although fluoroquinolones also exhibit concentration dependent killing of bacteria, excessive high serum concentration of this agent can unfortunately be associated with seizure and other potentially serious renal CNS adverse reaction. This has been the major reason why fluoroquinolones cannot be dosed at very high concentration. When peak by MIC ratio greater than or equal to 10 cannot be reached without excessive toxicity, then the time of exposure of organism to drug cannot be ignored. The bacterial eradication again becomes the function of concentration and time of exposure. Most of the currently available fluoroquinolone given at usual doses, even orally, achieves urinary concentration far above 10 times their MIC for even difficult organisms like Pseudomonas. Despite ciprofloxacin, slightly lower MIC against the bacterium compared with levofloxacin and gatifloxacin, the patient's outcome are same with all the fluoroquinolone becomes because they all attain urinary concentrations greater than or equal to 10 times their MIC against the bacteria. Interestingly, the only fluoroquinolone that was contraindicated for treatment of Pseudomonas aeruginosa urinary tract infection is trovafloxacin because of its very low urinary concentration and its relatively high MIC for these organs. Moxifloxacin is also unwise choice because only 25% of active drug is eliminated in the urine. This is the reason why microbiology lab do not report the susceptibility of any urinary pathogen. The percentage of the dose of the ciprofloxacin, levofloxacin, and gatifloxacin eliminated in the urine are 50%, 90%, and 90% respectively. For evaluating the efficacy of fluoroquinolone, the PKPD concept used for predicting outcome in urinary tract infection is concentration in the urine and MIC greater than or equal to 10, where in systemic infection it is area under cover upon MIC. So examples of the concentration dependent antibiotics are aminoglycoside, fluoroquinolone, and cyclic peptides. Thank you guys.